Hi, I'm Chrissy Giuliano, the Executive Director of the Big Cities Health Coalition. The Coalition is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly work together on things like policy and other public health challenges. We have 30 members in the coalition, which are generally the largest and most urban cities and the health departments that they serve across the country. In a few minutes, you'll hear from two of our member cities, Columbus, Ohio, and Minneapolis, Minnesota. Dr. Mashika Roberts from Columbus will talk about all they are doing to address vaccine hesitancy in their communities of color. And you'll hear from a team in Minneapolis hearing about the work they're doing to engage the community. Before they share those thoughts with you, we wanted to share a few high-level points on behalf of the coalition. First, it's critically important for the federal, state, and local public health enterprise to work together in tandem. We know how important a comprehensive, federally led and resourced detection and response infrastructure is to responding to challenges like COVID. Though it needs to be carried out and developed with local and state partners, it's critically important that, again, states and locals are seen as true partners, providing situational awareness of what's happening on the ground and working with the federal government and partners, again, at the state and local level to inform what's needed for the response. The information that state and locals can share with their partners really needs to feed into in all of government response. The lack of comprehensive national guidance and messaging in the early days of COVID-19 led to a patchwork of activities across jurisdictions, which was not always based on science and data. It's also really important that we update our data systems to make them more comprehensive and timely. It's well documented that the governmental public health system's data infrastructure, particularly at the state and local level, is lacking. A continued investment over the next decade at the CDC that provides funding directly to support state, local, tribal, and territorial health departments could transform today's public health surveillance system into a state-of-the-art, secure, and fully interoperable system. An immediate, large, and sustained tranche of federal funding must be given not just to states and not just the CDC, but also local jurisdictions to truly enable this 21st century data infrastructure and strengthen information sharing from the federal all the way down to the local level and back up. CDC should also work to evaluate the current electronic lab reporting system. As this task force knows, demographic data was and still remains a challenge to collect related to COVID, which according to some is due to existing lab reporting systems. CDC and partners across the administration should assess and report out on the status of these systems, and dollars need to be provided to upgrade them as necessary. Federal entities need to take both federal capacity and local health department experience into account when making future recommendations in order to accurately detect emerging infectious disease. For example, many large local jurisdictions are in favor of a centralized data collection tool and technology systems with standardized capacity metrics, immunization records, and definitions, and would be eager to collaborate with the CDC and federal partners to ensure that this tool is created in such a way that its uptake would be swift and effective. Finally, as the task force knows all too well, health disparities and inequities in the United States are neither new nor unique to COVID-19, but instead are driven by structural and social determinants of health, including hundreds of years of systemic racism. In order to adequately address the disproportionate impact of COVID-19 on communities of color, we must act now to ensure that those most impacted are reached and resourced and treat racism as a public health crisis by examining not just our health systems, but also looking at the very fabric of our economy and our communities. Achieving equity and good health for future generations is BCHC's mission, and achieving this will not be easy. Acting on racism through a public health lens may help to reframe the conversation and illustrate that we are all only as healthy as the least healthy among us, as this pandemic too has shown. But doing so will mean rebuilding our communities and in some cases the systems within which we operate, so that each and every person, no matter where they live, the color of their skin, where they were born, has the opportunity to live a healthy and productive life. We at the Big Cities Health Coalition stand ready to work with you as you move forward with your charge. We thank you again for this opportunity to share thoughts with you, and please do not hesitate to reach back out to us if we can be of more assistance. Now you'll hear from our members. Thank you.
Racism is the root cause of long-standing health inequities that have left Black and Brown communities more vulnerable and at greater risk of severe illness and death from COVID-19. Yet across the country, we are seeing much lower vaccination rates from African Americans than for whites, leading to poorer health outcomes of people of color. The reasons are many, including mistrust, misinformation, access, and historical mistreatment by the medical community. The Tuskegee experiment and the legacy of Henrietta Lacks are not far from mine for many people in this country. Vaccine hesitancy is real, and we must acknowledge it. It will take all of us in every community, large and small, working together to address the challenge of vaccine hesitancy and increase access for communities of color. We must reach and engage vulnerable communities where they live and work to remove barriers like transportation, time off work, and childcare. We must entrust influencers like pastors, physicians, and community leaders to carry accurate information into the community and address the myths and answer the questions they have. And we must increase access by getting vaccines into our most vulnerable neighborhoods, considering all factors that impact health, such as income, race, medical conditions, and transportation. Our country's ability to win the battle against COVID-19 is contingent on making sure we reach and vaccinate our Black and Brown communities who are at most risk. When we protect the most vulnerable among us, we protect our entire community from COVID-19.
Related to engaging marginalized communities in the COVID-19 response, something that we really focused on in Minneapolis is getting started early. Early on in our response, we worked to build community relationships that were new, but also to include community relationships that we've been working on for some time, and where we have confidence and we have trust that existed already. Something we did very early on was including community members in the decision-making process at the beginning of our incident management team being stood up in this response. We called that group our SPAC, our Shared Power Advisory Committee, made up of over 20 individual community members represented from all over the city. And we met twice weekly to inform the decisions that were being made at the beginning of our COVID-19 response. That was really an integral component of making a lot of decisions that were relative to community needs and centered the importance of some of those issues inside of the community. A good example of kind of how we were able to move beyond that into application is, I think, beyond the time where we were doing planning and the initial response and the distribution of PPE, but getting to the point where we were also doing vaccinations. And those relationships that we had and we had built in areas of the community where we needed to put more effort and energy enabled us to start doing vaccinations with our public housing partners in a very intentional way. And that included providing a lot of information that was requested, making sure that we had community health workers and translators on the ground to provide information to make folks comfortable with the information that they were getting about vaccination and empowered to make a decision for themselves. We also were able to include those relationships that we've built in community and clinic linkages to extend through telehealth and being able to provide a lot of different ways for folks to connect with that information and the ease of going into buildings to provide vaccination on site rather than having to move into a space where we would be transporting folks or expecting that folks transport themselves. Beyond that, we were really intentional about creating our PIO, our public information and outreach section of our IMT to really reflect the gaps in information that we were learning about. Not just that folks couldn't get information, but that information was being regularly released in English first, and then a number of days or even weeks later, being able to release that information in multiple languages. We've done that through also engaging community partners in helping to develop those messages and focusing on transcreation rather than focusing on just translation of English materials. It's been really integral for folks to get information in real time and to be empowered to make decisions for themselves based on that information. A lot of that has also relied on our relationships with community members and trusted messengers to not only get our messages out, but also to make those messages themselves for moving it forward. Some things that we learned throughout this is to really rely on built relationships and to start building those relationships early. Building a relationship with a community member or an organization once the emergency has already started is very difficult. Relying on relationship building techniques that begin long before the emergency has been defined has been really helpful. It's an area we've excelled and an area where we have a lot of work to do. Emergencies are different for every person and every community, and learning what that means for folks before we get to the point where action is imminent really helps us to make the best decisions and to make the most of the resources that we have to distribute to tackle these big community issues. Something else that we learned the hard way is to really think about equity from the beginning, to immediately let that drive us and not to forget until the time of implementation comes in to think about the tactics by which we will be equitable and we will be inclusive. So getting ahead of those conversations, even though we started having them, our systems weren't built to implement things in an equitable way right from the get-go. So we've really learned to think about our internal systems and how they relate to equity throughout the entire response and in our preparation to begin the response. Something else that we've learned is around the shared power in decision-making, not only in the implementation, but in how we decide to do the work, how we define the problem. Really engaging the members of our SPAC, really leaning on the trusted messengers with whom we have MOUs, memorandums of understanding, throughout the development of our communications messages and our vaccination programs have really been important for making sure that the interventions that we're doing are actually the things that community members need. As we move beyond this and we're able to take this time to reflect and think about how we could do better in the future, we're really hoping that we can always focus on having the ability to get community contracts in place that are with community organizations and even with individuals that really give us the opportunity to co-create solutions and implement them in a timely manner. The compensation for community members and lived experience has been critical to evening the playing field and making sure that the shared power in decision-making is authentic and we're able to follow through on it. We also hope to be able to continue a holistic approach to emergency preparedness and to the response associated with emergencies, because that holistic approach allows us to really focus on all of the needs that are associated with something that would be an emergency. For our response inside of the COVID-19 pandemic, dealing with all of the social determinants of health that are related to this emergency has been an important part of being successful. A person who is thinking about whether or not to get vaccinated for COVID-19 is also thinking about housing and employment and safety for their families. And it's really important that we're able to work in an intentional way with cross-sector collaboration as a centerpiece of our community engagement and the development of our response. Having the funding early on to build these relationships and honor the relationships and get those relationships in place on purpose before we actually have to start acting is really important for making sure that we have a good footing to move forward. Something that we noticed early on was that we didn't have the funding in place to get these relationships up and running at the beginning when we needed it. So really thinking about how we can have funding that's pre-allocated for local public health to honor these relationships with community-based organizations and individuals is really important to making sure that we already have the structures built and we have the relationships built before we need them inside of the pandemic and or the whatever future emergencies may come. something that would have been really helpful early on is funding for communications and for translation. Something that we noticed all throughout was that we didn't have enough people to speak to everyone in our community. It's a major metropolitan area, and it is full of many languages and many cultural approaches and many different ways of receiving and interpreting information to make decisions. So something that is really helpful is having that funding already in place for communications, for community interventions, for collaboration. And often we see that funding is tied directly to a specific outcome. For example, get XYZ amount of vaccinations in a certain community versus having that ability to have funding that is flexible. Ideally, we're able to pass that out because we've been able to focus on data collection to know where we need to be, to know what interventions need to be in place, and then to be able to reach out to community to share that information with them and have them participate in making those decisions. But that means we need a lot more of the money on the front end so that we're able to engage in that way.
7 months focusing on relevant communication and providing information that addresses questions, concerns, fears from our marginalized populations. So as you know, vaccination is a whole, specifically COVID-19 vaccination is a whole different, a new thing that came and struck us really hard. And the key was really understanding where our communities of color were since the beginning. And something we did in the health department that was actually something that was inherited from the community engagement work that Heather just mentioned, was to tap into what community members wanted to see about vaccination efforts moving forward. So we did drive a survey that helped us understand where community was around vaccination, what their feelings about vaccination were, what they wanted to see, how they wanted to see it, and when they wanted to see it. So we put those findings from that survey and we turn them into guiding principles for our communication efforts moving forward. When we talk about communication, we talk about two main things, which is trusted messengers and trusted messages. So with that platform, we leverage on our relationship with 5 partners, community-based partners, representing each one of our priority communities. Those communities were the Native American, African American, East African, Latino, and Asian Pacific and Islander communities. So focus on each one of those communities, prioritizing these specific communities. We engage into the process of sharing vaccine information through their efforts, being the trusted messengers, doing on the ground efforts to connect with our community members and talk to them about vaccine and why it was important to get vaccinated to protect their communities, their families, and the city. One thing we learned from that interaction, especially with our community-based partners, is that it wasn't just as simple as here's the information, share it out, you're the trusted messenger, you know how to do it. It was more about also listening from them. As they were doing that approach, they would come out to us with needs and with concerns or with things that we didn't have. So how we work together from there to co-create materials that were needed and that were relevant for these communities. So this is where we approach the whole concept of how we engage into the creation process, listening to what are the main concerns that the community has, what in what material that can be developed, in which language, how should be the tone. And you have to be prepared. I mean, we're talking about community members representing community groups. And sometimes the feedback can be brutal. Sometimes it could be challenging because that's, they come with great perspective in great resonance as why they are asking you for certain things. So you have to being able to take a step back and listen and incorporate those thoughts and insights into your plan. So that with that, we developed several materials, starting with our vaccination website, vaccine informational sheets, vaccine event flyers. We developed a social media toolkit. And let me explain to you a little bit of how we developed that, starting from the insights, hearing community members telling us what they need. And what we wanted to do is to have cultural context to be cultural appropriate, linguistically also being able to have it in different languages. And the way we took this approach, it wasn't just creating the English version and translating it, because as the PIO lead, I do not believe in translation. I believe in transcreation, where you really get the essence of that message. And you might be able to use different words to describe that essence, but at the end of the day, you are getting your message straight to what the audience wants to hear, or you wish the audience to understand or learn. So from that perspective, we took the insights, we applied the cultural context, the needs, the concerns, the meaning of this message, and then we created them in the language of the specific audience. So again, I mean, I know that's we're talking about resources today and how we would like to see this in the future, and really an approach, a meaningful approach to communication efforts that are culturally specific, culturally relevant, and also that includes several languages that our communities speak. Once you develop that material, then you can partner up with your trusted messenger to come out with a good message and a good approach to share that message to your community.